Okay, for the final part of respiratory, let's see here. Let me fix this. There we go. Okay, we are screen sharing and we are recording. All right. So now we're going to talk about vapotherm. High velocity nasal insufflation. You don't have to remember that. It's just like heated high flow nasal cannula, but the device that we use on the pediatric floor is vapotherm. And you will also see this device in some of your adult units as well. So if you look here in this picture, some of you have seen it in a setting, not necessarily in use, but in the clean utility room. We have settings that look like this. This is exactly what our machine looks like. 8-liter flow, 40% FiO2, 36 degrees Celsius. As the nurses, we do not set this up. We do not mess with the temperature setting. We are responsible for making sure that the cannula device stays in place as it should and recording the liter flow and the FiO2. Remember, FiO2 stands for fraction of inspired oxygen. So that would be FiO2. So that is fraction of inspired oxygen. So, you know, room air is 21%, and the most we can go up to on a patient is 100%. Oftentimes, the patient does not necessarily need the high percentage of oxygen, but they can benefit greatly from the flow. So you can see on this patient, they're on 8 liters of flow, which is a lot of flow, but only 40% oxygen. So basically what vapotherm does, it reduces the work of breathing, the retractions, the labored breathing, by washing out the CO2 from the upper airway. And I'll explain that a little bit more in a moment. It's delivered through a small prong nasal cannula. It's a little heavier than a typical nasal cannula. It looks the same, except the tubing that the nasal cannula piece is attached to is heavy because it has the heated, the humidity, and it's just heavier. It actually has a little clip where we can clip it to the bedding, the linens, so that it doesn't drag down on the patient's face. It's heated and humidified to make those high flow rates more comfortable for the patient to tolerate. And that high flow is flushing out the carbon dioxide as it fills the upper airway with oxygen, fresh humidified oxygen. And the humidity in itself is beneficial to help clear the mucus from the airway. So if I dare draw you a picture, we'll try this, okay? So you have, here are our lungs, and this is our airway. So when a patient is attempting to take in a breath to get oxygen down the airway into the alveolar sacs, okay, the gas exchange occurs here. When they're working hard, they have to overcome all of this dead space. This is called dead space. It's just where the CO2 is leaving and the oxygen is coming in, but no gas exchange is actually occurring here. So it's a wasted space. If we can eliminate this space, so if we can, oh, I didn't mean to erase that much, but if we can eliminate that dead space by that high flow coming in under such high pressure that it is literally flushing out the CO2. The CO2 is constantly being flushed out by the oxygen that's constantly being pumped in. So as soon as the child attempts to inhale, the oxygen's sitting there. This is our oxygen down here, just sitting there, right at the alveolar space. The CO2 is literally pushed out of the way by that high flow. The child doesn't have to exhale the CO2 out with great force or try to inhale the oxygen with great effort, because the CO2 is constantly being flushed out and the O2 is constantly being pumped in. So the slightest effort on the child's part delivers the oxygen. That's how vapotherm works. And yes, that high pressure does have some small benefit of helping to maintain PEEP, that positive end expiratory pressure, but overall it has to do with eliminating that dead space and making the oxygen more readily available for the child. This came from the Vapotherm website, and it just gives you some different things here that, you know, why patients that could benefit from Vapotherm, those in distress or hypoxic, tachypnic, they're having accessory muscle use, things of that nature, nasal flaring, and they could benefit. And these are some different diagnoses that could also benefit from Vapotherm. So we see this with our adult patients as well as our neonates and our pediatric patients. Things that we need to monitor for when we have a patient on Vapotherm, of course, their work of breathing, their pulse ox, their CO2, if we're drawing blood gases in a more critical care setting, a more acute setting, or measuring end-tidal CO2, which honestly I've never witnessed Vapotherm and end-tidal being used at the same time, but some places may do that. And of course, we need to watch the FiO2 and the liter flow. We must make sure the nares are patent. If the nares are clogged up with crud, this isn't going to do much good. Another thing is feeding tolerance. We're pumping a lot of air into these babies, and sometimes in children, they can maybe swallow too much air. We have to monitor for abdominal distension and just the feeding tolerance overall based on their level of respiratory distress. But oftentimes, applying the Vapotherm will decrease respiratory distress, decrease the respiratory rate to an extent that they might actually be able to eat. But that's what we're watching. So as far as my documentation, of course, I've got my assessment documentation, but my pulse ox, my FiO2, and my liter flow are what I'm documenting. So here you have the flow rate, the FiO2, the temperature and water level. I mean, you can document the temperature if you want, but honestly, I don't know off the top of my head what the temperature should be. And the water level, you know, that's managed by the respiratory therapist. And then the nasal cannula size as well is placed. That's the respiratory therapist's job to set that up and make sure that that's appropriate. How does Vapotherm help the baby with RSV? So say you have a baby with RSV and the parent says, well, why do we have to have this nasal cannula on? It's so heavy and bulky, and I'm scared to hold the baby because I don't want this pulling on their face. I'm afraid to hold the baby with this attached to them because it does look a little more aggressive, of course. So if they ask, how does this help compared to a nasal cannula? Think about how you would explain the function of Vapotherm and the purpose of it. Go back to that first slide here and imagine yourself having to teach a parent about the benefits of Vapotherm. Vapotherm is a lifesaver. It is a bridge. Well, not really a bridge, but it fills the gap when a child is in such distress that previously our only choice, or one of our top choices, would be to have to intubate that child to help relieve their work of breathing before they exhaust themselves. Before, that was our option, but now we have Vapotherm that can fill that gap. When we have a child that we are afraid is going to exhaust themselves due to their work of breathing, we apply Vapotherm and we see miraculous results. It doesn't always prevent intubation, but oftentimes it can help ease the work of breathing over the worst of the illness, and it can prevent them from needing to be intubated. So it's a great invention, and we use it a lot. In asthma, same thing. It can reduce the work of breathing during an asthma attack. It also promotes bronchodilation. Oxygen in itself does that, and relaxation of smooth muscle, it helps with that. So there are many instances where it is beneficial. On this picture, I am simply exposing you to what a ventilator looks like, okay? In third level, hopefully you will get a chance to explore an ICU setting, and you may run across something like this called a servo vent or a VIP bird vent, a Marquette vent. There's different ones, but this is your basic ventilator. And you can see here where you have corrugated tubing, plastic tubing that leaves the ventilator and connects to the patient's ET tube. And here we have what is called a graphics package. That is our screen where we read our settings. Let me back up here. So if we take a closer look at our screen, and you can see how it graphs images here, and that's why it's called a graphics package. We have our mode, which this patient is on a volume control mode. There are different modes that you will learn if you work in an environment where they have ventilators. SIMV, which is spontaneous, intermittent, mandatory ventilation. PRVC, pressure regulated volume control, pressure support, volume control. There's lots of different modes. So again, the respiratory therapist is the one that manipulates these settings. It is not in our job description, and you can get in a lot of trouble for manipulating ventilator settings because we have not been trained to do that. There are certain things that nurses are expected to be able to work on this machine, and I'll go over that. Down here along the bottom, we have dials, little knobs that rotate. These dial in specific settings. So at a glance, I can see that the FiO2 that this patient is being administered is 35%. So if you think about room air being 21% and the maximum being 100%, 35 is not too bad. Usually just the fact that they have warranted intubation and bought themselves a ventilator, I rarely see it go less than 25% oxygen, just for good measure. So 35 is not too bad. That means they're not requiring that high of a percentage of oxygen. They're able to oxygenate with just a little bit of extra oxygen. And then here we have a PEEP of 6. And if you will recall, we discussed earlier that PEEP stands for positive end expiratory pressure, and that is the amount of pressure that it takes to prevent alveolar collapse at end exhalation. So when you exhale, you don't want the alveoli to completely collapse, or you would have to create more pressure to take the next breath. You would have to exert more force to have more of a negative inspiratory force to create, to open those alveoli so that you can have gas exchange with that next breath. So God gave us physiologic PEEP, where our alveoli, on a good day, they stay open and they maintain a PEEP of like 4 to 6, just in any healthy, normal person. So the fact that this patient on a ventilator is only requiring a PEEP of 6 is totally normal, because 4 to 6 is normal for someone who is not on a ventilator. So that's good. So I'm not alarmed by my oxygen requirement, and I'm not alarmed by my PEEP requirement. These are settings ordered by the physician, okay? The respiratory rate is what the next number is. That is the dialed in rate that we make sure that the patient receives a good deep breath. At least 15 breaths per minute are ensured. And whether or not the patient is allowed to initiate their own breaths or take their own breaths, or if the ventilator demands that it administers the breath, that depends on the type of setting, and we won't get into that now. Just know the basics: oxygen concentration, PEEP, respiratory rate, and then the tidal volume. And tidal volume in general, there's a formula: 5 to 7 cc's per kilo, or milliliters per kilogram, is the typical tidal volume. So that's the total amount of air that is being, volume of air that is being put into the lungs with each breath. So with this patient, we could assume that 15 times a minute, they will receive a full 500 milliliter volume breath. And then on the side here, we have the actual measurements that it, according to, what the patient is actually doing. Here we see this patient is actually only taking 15 breaths per minute. So if I see a rate of 15 here that's dialed in, and I see that the patient truly is only taking 15 breaths a minute, that means they are either just really in sync with the vent and they don't need more breaths than that, or they're not trying. They're not breathing on their own at all, and every breath that they take is being delivered by the ventilator. When these numbers match up, that's usually what it means. And it could be because we have them sedated to the point that, so they don't fight the ventilator, that we want that, or it could be that their neurologic function has deteriorated to the point that they don't have a respiratory drive. And then here we have a reflection of our oxygen, our FiO2 of 35%. And these numbers on the bottom, don't worry about, that's the respiratory therapist's job. But up here, this is another number that I pay attention to, the peak pressures, the 26 peak pressure, and it's kind of like a trend. So if I come in and the patient is calm, they're not struggling, they're not coughing, and I see a peak pressure of 26, and then 30 minutes later, I hear some alarms going off on the vent, and I see the patient look like they're choking or coughing, or I hear gurgling in the ET tube. This number is what my eyes are going to go to. A lot of times this number will change colors, and it might be flashing to show me that this is what the alarm is generated from, and this number probably jumped up to 45 or 50. And I know that when we were good, we were 26. So it tells me that all of a sudden we have a really high pressure happening inside that breathing tube. Why could that be? Well, it could be anything as simple as the patient biting the tube and causing a kink in the tube, causing an occlusion, or they're coughing against the tube, so the peak pressure jumps up until the coughing subsides, or in combination with that cough, the reason they're coughing maybe is because they have secretions in the tube. And if you think about it, if their breathing tube, their ET tube coming out of their mouth is connected to this corrugated tubing here, and they have secretions that they need to cough up, they can't cough them out because there's nowhere to cough them to. So they might cough the secretions up into the tube, but when they take a breath, they suck them right back down. So that's why we have to suction our patients. So the peak pressure oftentimes means that there are secretions clogging the tube, causing an obstruction, and they just need to be suctioned. So that's a basic overview of your ventilator. As far as what the nurse can manipulate, there is a button right here that says O2 breaths, oxygen breaths. So you were taught in first level to pre-oxygenate your patient prior to suctioning. So this button will allow you to deliver 100% FiO2 for 2 minutes, and then it will automatically revert back to 35%. So you could push this button while you're putting on your sterile gloves and preparing to suction. That 35 will automatically change to 100%, and it will stay there for 2 minutes. And then afterwards, if the patient needs a minute to recover and their SATs are dropping, you could always push that button again. It's a temporary increase to 100% oxygen. And then There are some other dials, but really other than the oxygen breath button and the silence button, which I don't believe we can see from this point of view, but it's over here. There's a silence button. If it's alarming and you're standing at the bedside preparing to address the problem, you can silence the alarm temporarily and you can give an oxygen breath. But other than that, we don't really manipulate those settings. And then here we have a picture of an oscillator, which is a high frequency oscillatory ventilator, high frequency oscillatory ventilator. So when you think of oscillations, think of, oh gosh, I don't know how to describe that, but it causes the baby's chest to wiggle and shake, oscillate. So what happens? The machine looks like this. It's a big, ugly, bulky machine. And the tubing, instead of that corrugated tubing that connects the ventilator to the patient, it's a very stiff type of tubing. So we have to be more careful not to dislodge their breathing tube when we're repositioning. Adults, babies, and children all are placed on this oscillatory ventilator as needed, and it looks the same no matter the age of the patient. But this would be a step up from your regular ventilator. So the patient did not tolerate regular ventilation with the standard ventilator. Their lungs are so sick that we're not able to oxygenate them the way that we need to, or maybe their lungs are so fragile due to illness or prematurity that we need a more gentle way to ventilate them, and that is what the oscillator will do for us. So high frequency ventilation is a strategy that uses a form of ventilation that combines very high respiratory rates with tidal volumes that are very small, smaller than the anatomic dead space. So when I say very high rates, respiratory rates, guys, I'm talking about up to 900 breaths per minute, 900 breaths per minute. The rationale for this type of ventilation would be that gas exchange is optimized by utilizing small tidal volumes with minimal alveolar stretch. So picture the premature baby's lungs that are very, very fragile and are not formed to the degree that they are ready for gas exchange in the world, right? So their lungs are so fragile, we want to minimize scarring and damage to those lungs. So we can put that baby on an oscillator and give them little tiny breaths, 900 breaths a minute, up to that, with little tiny tidal volumes to decrease the amount of damage on the lungs. The rate is so fast that the airway pressure just oscillates around, and it's constant. There's no big force in, big force out. You can put your stethoscope on a person on a ventilator and you do not hear inhalation, exhalation. All you can hear is the vibrations. It's called an oscillatory wiggle. That's what we would document, that there is equal oscillatory wiggle, equal chest wiggle, because they literally just vibrate. And that constant airway pressure maintains the alveolar recruitment, or keeps the alveoli open. It doesn't allow them to collapse. It avoids those high peak airway pressures, and it has a big impact on our ability to oxygenate them. So a higher mean airway pressure, which is one of the settings on the machine, is directly associated with better oxygenation. So gas is pushed into the lung during inspiration, and then it is literally pulled out during expiration without the baby having to make those inhalation and exhalation motions. So in some preemies, like I said, this high flow oscillatory ventilator or oscillator may be the first line vent. Like we don't even need to fool with the standard vent because they're so susceptible to lung injury from conventional ventilation. So sometimes we skip straight to this vent when we have good reason to believe irregular vent would cause damage. So if that fails, if we've tried the standard vent, we've tried the oscillator, and a patient's lungs are deteriorating so quickly that we feel like oxygenation is not happening, it is just not effective no matter what we're doing, there is another option called ECMO, extracorporeal membranous oxygenation. And I'm just mentioning this to you. I'm not teaching this. I'm not testing on the ventilators, the oscillator, or ECMO. I am just showing you what respiratory failure can lead to in the pediatric population. So ECMO, on a very basic level, we would have cannulas inserted into a large vessels, and one of the cannulas would draw blood out of the patient, and the other cannula would put the blood back in the patient. So when the blood is drawn out of the patient, I don't think we can actually see the device here where the exchange is happening, but when the blood is pulled out, it is run through a machine that performs oxygenation on the blood. So when the lungs can't do it and the lungs need time to heal and just rest, we can leave the lungs connected to a ventilator such as an oscillator to keep those alveoli open, to maintain recruitment of our alveoli. So we leave them on a ventilator, but we turn the settings down very low, very gentle, and we just let those lungs rest. But to perform the actual oxygenation of the blood, we run the blood through a machine, and the machine oxygenates the blood. So it's extracorporeal membranous oxygenation. The machine performs the function of the lungs. And you can imagine this is a very high acuity patient. Sometimes takes more than one nurse to care for one patient. It might be a 2-on-1 patient, or depending on their level of acuity, even a 3-on-1 patient, meaning multiple nurses are required to keep everything running as it should. You can see here all of the, this here is a type of oscillator called a jet vent. You have a baby and a radiant warmer. Here is our, this is another type of ventilator here. Here's the machine, and we have all of this is part of the ECMO, where the blood is running through all of these devices, multiple syringe pumps. We would have things like this called a tree, where we would have everything's running with its own brain, multiple syringe pumps, probably vasopressors, because you can imagine it's almost like a form of dialysis in a way, but not really. But we would have to be very careful to control blood pressure issues and fluid status and things like that. So these are very high acuity patients. It used to be, when I first graduated nursing school, this was a last ditch effort, but now it's something that we don't wait till the last minute on. We know how to do this. We know how to perform ECMO safely on a patient. We know ahead of the time, this patient is headed towards ECMO. We know ECMO can be beneficial for them and can save their life. And so now providers don't wait as long to attempt ECMO. So just now you know what a standard ventilator might look like and the basic settings on it. If you saw one, if you see this big ugly rectangular box with this stiff tubing here, you would know, and you see a wiggling patient, that's an oscillator. And it's giving very, very fast, small volume breaths for more high risk lungs. And then we have ECMO. So that's all I'm gonna say about that. And then for bronchopulmonary dysplasia, or BPD, just in case I do not cover this, which I don't think I do, I want to throw this out there too. So when I say BPD, I want to separate that from, let me type this. It is not the same as respiratory distress syndrome of the newborn. That is a totally separate thing, okay? So I'm gonna stick this over here on the side, and we're gonna talk about that in a minute, okay? So BPD, bronchopulmonary dysplasia. Some textbooks call it chronic lung disease. We kind of went through that phase, and now we're reverting back to the older term of BPD, which I prefer because chronic lung disease sounds like COPD. It sounds too close to COPD to me. BPD is something that we only see in premature babies. So take a minute right here and look at these lungs. You know from the x-rays that we, stop. How do I make that go away? Clear, I have no idea. So we're just gonna scoot it out of the way. How about that? So if I touch my magnifying glass, there we go. Oh my. Y'all, why am I so computer illiterate? Does it make you laugh? I hope it just really makes you laugh because it's embarrassing. Have mercy. Forget that magnifier. Just go away. Go away. You can look at those lungs and see that they look like fuzz, cotton ball, all in those lungs. And that is not, that doesn't look good, right? We see here we have our NG tube with that radiopaque line sitting in the tummy, and we have an ET tube here as well. And due to the positioning of the patient, you can't really tell if that is in the proper position because the baby's head is turned and it's changing the way it really is. So anyway, turn to page 1062. 1062, there's a pathophys box that talks about BPD, and on page 1065, it also discusses BPD. This is something that is diagnosed in infants typically that are born before 28 weeks of gestation. So these are preemies born before 28 weeks, typically, who are still dependent on oxygen on day 28 after birth. So that's kind of easy to remember. So just think babies prior to 28 weeks gestation, so they're very small preemies, and on day 28 of life, they're still requiring oxygen. At that point, they can be diagnosed as having bronchopulmonary dysplasia or chronic lung disease. Think about the baby, if they're still requiring oxygen on day 28, then maybe they're off the ventilator, but there was so much damage caused trying to ventilate those premature lungs that the lungs have scarred, and they're left with this syndrome of BPD. There's no way around it, honestly, guys. All we can do is try to ventilate in the least invasive, least damaging way, but you got to ventilate them, right? So it's a catch-22. You got to ventilate, but you often have these side effects that the child has to live with as they grow up. So it's a very serious chronic respiratory disorder, and it's becoming very common. The better we get at saving premature babies, the more we have admitted to the peds floor at 6 months old, a year old, a year and a half, 2 years old with BPD. They have a history of prematurity, and here they are in the hospital due to something that would not put a full-term baby in the hospital because they're working with chronic lungs. They're like a little old man. They have little old man lungs instead of healthy baby lungs. The only way we can prevent BPD is to try to wean those vent settings down as quickly as possible and wean the oxygen down. Oxygen toxicity causes a lot of damage in premature babies. So we do not, that's where that FiO2 knob comes in handy, because as soon as we can get them down from 100% oxygen, where they start out at usually, to closer to 21% oxygen, then the less damage we are inflicting from that oxygen. So, but once they develop BPD and they have this chronic lung disease, it takes years for them to outgrow the damage. And sometimes they kind of never really completely do. So respiratory distress syndrome in the newborn. Respiratory distress syndrome, or RDS, is something that we only see within the first 24 hours of life. You cannot have RDS in any human unless it is within the first 24 hours of life. So RDS in this context is talking about a type of distress that occurs in the first day of newborn life. And this is due to, typically due to prematurity, because they have not, their lungs have not produced surfactant. So that would be spelled like this, surfactant. Surfactant is something that we need to lubricate our lungs for inhalation and exhalation. So if you, for that friction that's occurring within the pleural space, so if you don't have enough surfactant or any surfactant because you were born too early, then every time they breathe, it is painful and difficult, and it takes more effort to inhale and exhale because there's no lubrication there. We have a very simple fix for that. Surfactant is manufactured now and has been for a long time. So depending on the degree of distress, if the child, this is what we would try. You have a baby that's born early, we see retractions and distress within those first few hours, maybe even immediately. The physician will, or respiratory therapist will intubate that baby. While the tube is in place, we will squirt, like literally out of a syringe, squirt some surfactant into the breathing tube, give them a few breaths with an ambu bag to disseminate that surfactant into the lungs, and then extubate them, pull the